Welcome to today's webinar from the International Alliance of ALS MND Associations on Nutrition in ALS MND. For this webinar, we have English and Spanish captions available. If you're joining us live on Zoom, please check the chat box as we are adding the instructions right now. And if you're watching the recording in our YouTube channel, you will find the instructions in the video description on how to activate the subtitles. Para este seminario web tenemos subtítulos en inglés y español disponibles. Si se unen a nosotros en vivo vía Zoom, verifiquen en la casilla del chat, ya que estamos agregando las instrucciones en este momento. Y si está viendo la grabación en nuestro canal de YouTube, encontrará las instrucciones en la descripción del video sobre cómo activar los subtítulos. Thank you to our sponsor Mitsubishi Tanabe Pharma, without whom this webinar series would not be possible. For those of you who don't know me, I am Jessica May, Programs Coordinator for the International Alliance, and I am joined today by an incredible panel of experts who will address some key considerations on nutrition in ALS MND. Moderating today, we have Rachael Marsden, Consultant Nurse at MND Oxford, UK. After qualifying in 1987, Rachael became a primary nurse in a young disabled unit, where she worked for 16 years and gained a great deal of experience in the care and management of young people with highly complex disabilities. This gave her the perfect background to become the Motor Neuron Disease Care Center Coordinator for the Oxford Care Center in 2002. Having completed a degree and master's in rehabilitation, Rachael is now an independent practitioner and consultant nurse coordinating the care of people living with MND. When Rachael is not working, she is cycling, and she currently holds the world record for being the fastest woman to circumnavigate the globe on a tandem. Joining her in the panel, we have Guðlaug Gísladóttir from Iceland. Since joining Landspítali University Hospital in 2000, her career as a dietitian has been marked by extensive experience across various clinical settings within Landspítali, including inpatient and outpatient departments. Her recent years have been predominantly focused on the neurological departments, where she has specialized in the nutritional management of patients in both outpatient and inpatient settings. Guðlaug has played an integral role in the multidisciplinary teams dedicated to Parkinson's disease, stroke, and motor neuron disease, consistently basing her practice on the latest clinical guidelines and evidence-based research to ensure the highest standards of nutritional care. Guðlaug has also pursued further academic excellence by enrolling in a master's program. Her research project focused on investigating the food environment for individuals with MND, particularly those experiencing swallowing difficulties, with a special emphasis in pureed food. And joining Guðlaug in the panel, we have Madura Arunasalampillai, a registered dietitian since 2018 with a master's degree in dietetics from McGill University in Montreal, Canada. Madura has been working at the Montreal Neurological Hospital for the last 3 years, where she mainly works as an outpatient dietitian in the ALS clinic, movement disorder clinic, and epilepsy clinic. Madura also works on the inpatient ward, seeing patients admitted for strokes, hemorrhages, brain tumors, and various neurological disorders. Madura has been a speaker at the ALS Day Conference in Montreal for the last 2 years, educating the ALS community and healthcare professionals on the importance of nutrition in ALS MND. And completing the panel, we have Gwen Petersen, who will be sharing her perspective as a person living with ALS MND. Since her diagnosis at age 32, Gwen Petersen has poured her energy into advancing the science of her disease. Gwen's motivation behind participating in ALS research is to help move the needle towards the development of disease-modifying treatments for ALS and eventually cures. Gwen is not the stereotypical ALS face. She continues to share her story to dispel the myth that ALS is an older man's disease. Gwen is married to her best friend Nathan, and they are parents of an exuberant golden doodle named Annabelle. Prior to her diagnosis, Gwen worked as a recruiter for one of the top 10 medical centers in the US. Now, unfortunately, when we're doing these webinars, we do have some technical issues, and unfortunately, we have a problem with Gwen's introductory video. However, we will add it to the recorded version, so we do invite you to come back to this webinar once we publish it, so you can see what Gwen has to say. Now, some final instructions. Any questions you have for our panel, please write them in the Zoom Q&A box. And if you're watching from Facebook, you can add your questions in the comments. I also want to take this opportunity to thank everyone who pre-submitted their questions. There is a lot to cover, and we'll do our best to answer as many questions as we can in the time we have. I will now turn it over to Rachael, our moderator for today.
Thank you so much, Jess, for your introductions. And I have to say, it's an absolute pleasure to be here today because the importance of nutrition is a fundamental and underlying kind of element of MND and living well with MND. So this is such an important afternoon. Well, it's afternoon for me, it's morning for Jess, and it's evening, I think, for Guðlaug. So this is, I hope you very much enjoy the presentations. I have been able to have a look at Gwen's presentation already, and I'm sorry that you're missing it now because it just shares the information and talking about collaborative working, and I hope you will be able to see it at another time.
Hi, my name is Gwen Petersen. I was diagnosed with ALS in 2018 when I was 32 years old. I'm gonna talk a bit about nutrition today and some tips and tricks that were provided to me by my care team. So first up is about weight. Everyone's different. However, early on, I recommend finding a nutritionist, whether it's the nutritionist at your ALS clinic or your primary care provider who knows about ALS. That nutritionist can guide you as your ALS progresses and also as your weight changes. If you don't happen to have an nutritionist at your ALS clinic, you can refer to resources like the ALS MND Association nearest to you. You can also reach out to the Alliance. There are tons of pre-recorded webinars that these associations have on their respective websites. So again, if there's no one you can see in person who knows about ALS, please refer to reliable sources who have an understanding of nutrition and ALS. So with regards to the type of foods I eat, there are certain foods that I'm considering replacing as my progression continues, such as foods that may be harder to chew and swallow. So currently I'm working with my nutritionist on how I can replace the foods I still love that bring me joy and are nutritious, but replacing them with foods that aren't necessarily a choking hazard. If you have questions about supplements, there is a ton of information to help complement your diet and get you the nutrients you need. Please make sure to check in with your physician and nutritionist. They will advise you on what is locally available that will not cause you any harm. If you find something online, such as links to research papers, please bring these to your doctor and your nutritionist first, and they will confirm that they're from a reliable source. One thing that really helped me is creating a food journal. So what I mean by food journal is write down everything that you eat and drink throughout the course of a day. So with this food journal, you can bring it to your nutritionist and your physician, and they'll carefully review everything you eat and drink in a given day. Thank you so much for your time today. Thanks for joining. And you've got two really great presenters coming up after this. So please feel free to drop any questions or comments you may have about nutrition in the chat box. Thanks again.
So what I'd like to do now is to ask Guðlaug to start our presentation talking about nutrition upon diagnosis and dysphagia considerations, and thinking about texture of food and food looking good. Thank you, Guðlaug.
Thank you, Rachael. I will put and share the slides. Hello, my name is Guðlaug Gísladóttir, and I'm a
it's not sharing. Can you try sharing again?
Okay, sharing. Yeah.
You're all
Is
good.
it fine? Is it good now?
Yes.
Yeah, thank you. Yes, I will start. My name is Guðlaug Gísladóttir, and I am a dietitian at Landspítali, the University Hospital in Iceland. Today, I'm going to present nutrition upon diagnosis and nutrition and dysphagia. Malnutrition is common due to weight loss, less appetite, and increased energy needs. Studies show that malnutrition is observed in 16 to 55% of people with ALS at diagnosis. Lopez and colleague found people with ALS that generally lost weight and declined in nutritional status before diagnosis and before nutritional support. Also, they saw at follow-up that weight loss was less and nutritional status did improve when getting only a diet with adjustment in texture. Even more positive results were seen when artificial supplement in form of drinks was added to their oral diet. Mongolia and colleagues found that 20% of people with spinal disease onset had substantial weight loss before the diagnosis. More than half of people with ALS experience 5% or more reduction in their body weight over 6 to 12-month period. Weight loss is not recommended because it is thought to be protective. Normal appetite and food consumption are closely related to aesthetics and the human sensory apparatus. We decide whether food is appetizing through the senses: visual appearance, odor, flavor, shape, texture, and even food temperature and sound. To exemplify, we tend to eat less or not at all if the food looks unappetizing, smells bad, or somehow feels wrong. Loss of appetite is one of the symptoms leading to malnutrition that happens when people eat too little to meet their energy and protein needs. There can be many reasons for this. For instance, if people do not consider their food appealing and tasty. This is often the case with pureed food. Loss of appetite can also be caused by psychological and physiological factors. People with ALS have an increased energy needs due to hypermetabolism, which can increase the risk of malnutrition. Many issues of ALS can interfere with a good nutritional state apart from dysphagia, less appetite, and hypermetabolism. Constipation and salivary secretion problems may also cause reduced food intake. Also, if upper arms paralysis occurs, it may indirectly result in less food intake. Malnutrition is common in people with dysphagia because people with dysphagia may eat less if their fare is suffocating or because of little access of pureed food that have been texturized, shaped, or molded in a visually attractive way, recognizable on the plate, nutritious, tasty, and easy to eat. In addition, people have complained that pureed food often looks undesirable and stated that they eat less than needed. Malnutrition can and should always be prevented because it leads to increased neuromuscular weakness. The body needs to be in a good nutritional state to be able to function normally, and that is where healthy and nutritious food and regular meals play an important role. Meals also play an important role in physio-social well-being. Enjoying a meal with others is based on togetherness and is a big part in connecting people and bringing part of its environment in larger context, whether it is with the family or friends. Therefore, appearance of food and the way meals is served can have a direct impact on appetite and nutritional status. When a change in diet is needed, it can turn everyday habits and social life can be turned upside down with less appetite. To counterbalance the risk of malnutrition, healthcare professionals must use various targeted strategies. Many people with complain about the unappetizing look of pureed food that they need to eat due to dysphagia. Modifying a regular diet into visually attractive pureed food that have been texturized, molded, and or shaped in various attractive ways have been found to increase appetite and nutritional. The positive impact of producing visually attractive food should be emphasized when pureed food is needed. Therefore, meals are particularly important when providing nutritional advice for people who cannot consume food normally and thus need a modified diet. Teaching about nutrition in a proactive approach is important. This approach includes nutritional advice before developing problems with eating and drinking and frequent home visit to build a strong therapeutic relationship with people with ALS and their families. What can we do to improve nutrition status at diagnosis? Studies have provided evidence to support the use of hypercaloric, high-protein diet. This diet also involves using supplements with protein to aid muscle recovery, slow muscle loss, and prevent weight loss. Kellogg and colleagues conducted a systematic review of nutrition in people with ALS. The result demonstrated that supplements promote weight stabilization and weight gain. Therefore, an early aggressive dietary intervention is recommended because inadequate energy intake leads to weight loss and even muscle catabolism. Secondly, proper texture of food, so eating demands less effort, becomes safer to swallow, and extended meals prevent eating fatigue. Third, easy access to delicious food that have been transformed into texturized food that is visually attractive, recognizable on the plate, nutritious, and good to eat. Visually attractive food with an alluring flavor may increase the anticipation of food consumption and increase appetite. Poorer nutritional status has been identified in people receiving a texture modified diet compared to those on a regular diet. To exemplify, Hu and colleagues conducted a systematic review including 26 studies which emphasize this fact. However, when a pureed diet using silicone molds and nutrition enrichment, the nutritional status improved and mealtime satisfaction increased. These improvements were also reflected by healthcare professionals' experiences when a texturized molded pure diet was used. The Weiss study by Rachael and colleagues among hospitalized patients identified that pureed food more frequently ended in the waste bins than other diets in the hospital. The appearance of the meal and lack of variety of foods were the main reason for the waste. They concluded that food molds should be used to reform pureed food item, which increases food consumption, leading to better clinical outcome among inpatients. Here we see picture or photo, and that is an example of pureed food that is produced and served today in many healthcare places in the world. It is often difficult for people to recognize the food that is served. Therefore, they decline the meal. What do we need when making appealing pureed food that looks like a regular meal? Molded pureed food means food that is pureed into smooth paste, texturized and placed in a silicone form. Molded pureed food on a plate looks like a regular food. It has a significance and is very important for people and dysphagia to have meals that is palatable and look like others are eating with the same table. It is important to use recipes that have been tasted and adapted to the changing texture of food in terms of taste and color quality. Also important to use a good food processor, silicone form, and thickening agent before molded or shaped into their original appearance. Here comes an example of texturized food using thickening and gelling agents before molded and shaped into their original appearance. Another example of texturized meal using state-of-the-art thickening and gelling agents. That is the end. Thank you.
Thank you so much, Guðlaug. I think we do have some questions for you, but maybe we'll ask them after the next presentation because they kind of mix together. But I have to say, I have been in a good, fortunate position to have tasted some of those lovely molded foods, and they really are genuinely as good as they look. So we'll be able to come back to that with some questions after, if that's okay. But thank you. And I agree that pureed picture of pureed food is a little bit too familiar for my liking. They're all grey and yes, and not so appetizing. But thank you very much for that. Now we'll come back with some questions in a minute. But may I now ask Madura to give her presentation on talking about feeding tubes, what they are and the different types, and also she's going to talk about some myth busting, because there's lots of myths and thoughts about feeding tubes, but also importantly the timing of such a thing. Thank you, Madura.
Okay, can everybody see my screen okay?
Yes, you're all good.
Okay, perfect. So hello everyone, and thank you for having me. So as Rachel mentioned, I'm going to be talking about feeding tubes in people with ALS and MND. So first, this is kind of like a brief agenda of what I'm going to be covering today. So the first thing is that we're going to be talking about is what a feeding tube is. I'm also going to be talking about the different types of ways in order to administer tube feeding. We're going to also talk about when the appropriate time is to get a feeding tube, and as well as the benefits of tube feeding. So the big question is, what is a feeding tube? So kind of like how it sounds, a feeding tube is a tube that you're going to insert into the stomach. And with the feeding tube, you're actually going to be able to get a liquid formula, so tube feeding formula, that is going to be your food. And that's going to give you all the calories, the protein, the vitamins and minerals that you need. And this is all going to be inserted through the feeding tube. You can also give yourself enough water through the feeding tube so that you're adequately hydrated. And then finally, you're also going to be able to even give your medications through a feeding tube as well. So you just need to talk to your physician or your pharmacist to see if your medications can be crushed or if there's liquid forms of it. And with that crushed medication, you can actually dilute it in water and pass it through the feeding tube. So just to show you here, this is an example of what a feeding tube looks like. So the pull out portion here, with I hope that you can see with my mouse, that's the portion of the feeding tube that is actually going to be inserted through the skin into the stomach. And the upper portion here is the top portion that's going to be left hanging outside of your stomach, and it's not too long of a piece. It's like a couple of inches that's going to be left hanging out. So let's talk about some common myths that I hear about tube feeding and see if we can debunk them or not, okay? So I'm gonna make some statements, and just think to yourself whether you think these statements are true or false. So once you get a feeding tube, you can no longer eat by mouth. True or false? So the answer actually is false. So just because you get a feeding tube doesn't mean that you can no longer eat by mouth. In fact, a lot of people actually do a combination of tube feeding and still like to eat small amounts for quality of life. What you eat by mouth is not going to affect your tube feeding at any way at all, like the integrity of your feeding tube. So that's not an issue. And in fact, I have a lot of patients that really like to play around with the timing of when they get their tube feeding. So for example, I have some people that, get tube feeding for their breakfast and for their lunch, but for supper, they like to have a nice family meal and like to eat orally. So that is an option. Or some people actually still like to eat small amounts for all 3 meals, and then whatever they're missing in terms of calories and protein, they're going to get with tube feeding at the end of the day. So there really is options on how much you want and how much you can actually still eat by mouth. So the next statement is, you must make your own liquid tube feeding food or formula to administer through the feeding tube. So this is false. You can actually, there's a lot of commercially available ready-made tube feeding formulas that are specifically designed for feeding tubes that you can use. So they're already prepared, they're ready to use, so you don't need to make your own. This, however, doesn't mean that you can't make your own. So there's some people that may want to make their own tube feeding formula, which is not a problem at all. You just have to make sure that you do speak to a dietitian so that you're ensuring that the formula that you're making is high in calories and high in protein. And you also want to make sure that the formula that you make is liquid enough so that it can actually pass through a feeding tube. You don't want it to be too thick that it's going to cause any blockages. So you really want to speak to your dietitian about that if you want to make your own formula. However, there is many available on the market, and you can choose which one best works for you depending on how many calories you need, how much protein you need, and to see which one you can tolerate best. So for the final statement, it is never too late to get a feeding tube. So this is also actually false. So I know a lot of people are very worried about the idea of a feeding tube. It could be a huge psychological barrier for some people and a huge obstacle to get through. So because of that, some people end up delaying getting a feeding tube till the last minute. However, we do know that getting the procedure of a feeding tube can be a little bit more riskier if you're waiting till the last minute, and you want to make sure that you aren't doing that. We also know that the benefits of a feeding tube are highest when you do get it early on. So if you are waiting till last minute, the risk of it might kind of outweigh the benefits of getting it at that point. So you want to make sure that if you are deciding to get a feeding tube, you want to get that early on. But we'll speak more about that later in the presentation. So these are the types of ways of administering tube feeding. So these are the three ones that I'm going to be talking about. And depending on which one is going to be best for you, really depends on the equipment that is available to you, the volume of tube feeding you can actually tolerate, and the speed at which you can actually tolerate it as well. So the first one here in the first image is feeding giving through a syringe. So with that, it's actually all you need is really the liquid formula. So it's going to be usually in like a little bottle or a can, and then you have a syringe that you're going to use to suction the formula out. And then you're going to connect the syringe with your feeding tube right over here, and then push the formula in. So it's pretty simple. It's an easy concept to grasp, and doesn't require a lot of equipment, which is really nice. However, one thing with this is that people typically need to be able to tolerate getting larger volumes of formula at once. And the reason for this is that you're going to most likely need to give yourself multiple syringes of formula in order to kind of give yourself enough for a meal. And you need to be able to tolerate getting a larger volume at once. So not all people can tolerate this. This leads to our second option, which is feeding with gravity feeding. So with this is what you're going to get is an empty kind of feeding bag. And with this feeding bag, you're going to have tubing that's going to run down and connect to your actual feeding tube. And this feeding bag is usually hung up high. And what you do is you take your liquid tube feeding formula, you're going to pour it into the feeding bag to the amount that you need for a feeding. And then through the force of gravity, the feeding is going to be able to trickle down through the tubing and into your feeding tube. And you can there's a little bit of a little clamp to kind of change up the speed at which you're giving yourself the feeding. But this is a nice way to kind of control how much you're getting and not giving yourself too much at once with a little bit more equipment. And the final type of feeding is actually the pump feeding. So it's very similar to the gravity feeding, where you're going to hang a bag up and then have feeding run through the tubing down into your feeding tube. However, the tubing is first going to connect to a pump, and that pump is what's going to push the feeding formula down through the tubing into your feeding tube. And with this pump, what's really nice is that you can actually program the volume of feeding you want to give and the speed or the rate at which you're going to give the formula. So it's really nice because you can really control it that way, so people can tolerate going at a slower speed. If they tolerate slower speeds of formula, you can really change it up based on what you tolerate. And what's nice about the pump is that once it's programmed once and you're getting the same amount of feeding for each meal, then you don't have to keep reprogramming it every time. You just start it, and once you get your feeding, it's going to stop. So those are the 3 types, and really you want to speak to your dietitian to see which type of feeding is best for you. So now, when to get a feeding tube. So from the information, there's not a perfect, definite timing for everybody to get a feeding tube. We don't have that information. But what we do know is that the benefits of getting a feeding tube early on is highest when, the benefits of getting a feeding tube is highest when you do get it early on in the disease, especially if you do have bulbar weakness. So the weakness in the muscles involved with eating, with chewing and swallowing. And because of this, it's very important for healthcare professionals to be speaking to you about a feeding tube early on, so that you're going to be able to have all the information that you need about what a feeding tube is, what the uses are, the benefits of it, the risks of it. And with all this information down the line, when it does come time for you to potentially need a feeding tube, you have all the information that you need to make an informed decision. So not everybody is going to want to get a feeding tube, and that's okay. It's really important that that you do know what is best for you. And before you do make that decision, it is just important to speak to your healthcare professionals to see what are the consequences of getting a feeding tube versus the consequences of not getting a feeding tube, so that you really are able to make an informed decision. So if you do decide to get a feeding tube, these are some kind of points that might highlight when would be a good time to get it. So if you're starting to see that you're having difficulties with chewing and swallowing your food, and you're already modifying the textures and consistencies of your liquid, but you're still having trouble with this, and you're at high risk of aspiration because of it. So what I mean by high risk of aspiration is that instead of food kind of going down the regular way into your esophagus and into your stomach when you swallow, what you're going to see is that the food or particles of the liquid is instead going to trickle down into your airways towards the lungs. And this can actually increase your risk of getting an infection in the lungs. So we want to reduce this risk as much as possible. So if you're experiencing this, then this might be a reason to be getting a feeding tube. Another reason for getting it is if you see that the amount of food that you're eating is insufficient to meet your actual nutritional requirements. So there's many reasons why you might be eating enough. It could be because of a loss of appetite. It might be because you're having a lot of fatigue while you're eating, and it could be because of the difficulty with chewing or swallowing. So all these reasons can cause you to eat less, and consequently, what we do see is that when you're eating less, you do typically start to lose weight. And we don't want you to lose a ton of weight before getting your feeding tube. So once you start seeing that you're losing some weight, usually around between 5 to 10% of your body weight, then this might be a reason to start thinking about a feeding tube. Another reason to get a feeding tube is when we see that your respiratory function starts diminishing. So what we look at is your forced vital capacity, which is just a measurement of your breathing capacity. And this test can really determine how well your respiratory function is functioning. And once we see that the number starts approaching down towards 50%, then this could be an indication that you need to get a feeding tube. And the reason for this is that we see that you're actually able to tolerate the procedure of getting a feeding tube best when your breathing is at its best. And the reason for this is that during the procedure, you're going to need to lie flat on a bed and for at least about 15 to 20 minutes. And if you're having trouble breathing, that might be hard for you to do. We also see that with the feeding tube insertion, that you're able to tolerate the procedure well and also reduce the risk of any complications occurring when your breathing is at its best, when you haven't lost a ton of weight yet, when your weight loss isn't as severe, just because we know that if you're malnourished, then you have more likely to have a weakened immune system, have increased risk of an infection. So because of that, it's really good to try to get your feeding tube early on so that we reduce those risks and complications with getting a feeding tube later on. So I'm keep talking to you about the benefits of feeding tube, but let me just kind of mention what are these benefits. So one of the benefits of getting a feeding tube is that it helps actually meet your nutritional requirements. So you're actually able to eat the amounts of food that you want for quality of life, for pleasure, and then anything that you're not getting orally, we're able to supplement it with the feeding tube. And because you're able to better meet your nutritional requirements, we actually see a more stabilization in the weight. And for people that typically get a feeding tube early on, we even see some weight gain as well, which is really nice. Because that you're getting almost a lot of your calories and protein from your feeding tube and eating less orally, we also do see a reduce in the risk of aspiration, so food and liquids going down the wrong way. And a feeding tube is actually a great way to conserve energy because you're eating the quantities of food that you want and that you're comfortable with, and you're not fatiguing yourself to try to get all the calories you need. So you're just eating what you want and then supplementing with the feeding tube. And then finally, because of all these reasons that I mentioned, we do see that the feeding tube may actually help improve survival as well, but we do need more research on this. So in conclusion, I just want to let everybody know that feeding tube can be a very useful tool to help meeting your nutritional requirements, especially if you do have dysphagia with that difficulty with chewing and swallowing, and if you're really not able to meet your nutritional requirements through oral intake alone. So if this is something that you think might be right for you, really try to speak with your healthcare team, with your physician and dietitian, and start asking those questions of whether a feeding tube might be right for you, what are your concerns about them, and try to get those questions answered early on, because really timing is everything. You don't want to wait till the last second to get a feeding tube just because of the risks of getting it later on. So we really want to make sure that you do get it at the appropriate time. So thank you very much for your time.
Madura, thank you so much for your presentation. It's really interesting. And I just noticed when you were talking about the myths, one of your myths from America were talking about, do you have to kind of all home cooked food through the PEG tube? In the UK, we are completely the opposite. And I think it's because the tubes that we use are much thinner and much smaller. And so we're saying only supplements, water and medication carefully through the tube. But interestingly, talking about it last week, where the dietetics and the whole kind of nutrition community are thinking we're going to have to come and change our policies to become more in line with you, because so many more people are wishing to blend and have a blended diet and not so we're going to have to think about the size of the bore of our tubes as well, because we really discourage food being blended food down the tube, because with concerns about kind of blocking and things. So that's quite interesting. So we have a couple of questions. I noticed, Jess, there's one in the chat that's in Spanish, and I might ask, it's from Jose, and I might ask you to translate that.
I've replied to it. We just have questions around captions, so that's sorted now. Thanks, Rachel.
Thank you very much. See how good my Spanish is? I didn't know what that question was about. So one of the questions in the chat is for either of you. What are the options for somebody who chooses actually not to have a PEG tube? What then happens if they can then no longer eat or drink? Madura, should we ask you first?
Sure. So yeah, so for sure, if you already have all the information that you need and you decide that you don't want to get a feeding tube, then that is definitely your choice. So then you would really need to speak with the dietitian to see what are your challenges to eating, whether it be a loss of appetite and you're not eating enough, or if your main concern is dysphagia, so having difficulties with chewing and swallowing. So it would really need to identify what's your main limiting factor to eating enough and try to optimize that as much as possible. So if you're not eating enough because you're just not able to get the calories down that you need, We're going to try to enrich your meals as much as possible in order to get enough calories, enough protein in your meals. If it's really an issue of dysphagia, then we're going to try modifying the textures of your meals. So whether it be like, having more cut up foods, or if it's more leaning towards puree foods. So we're going to play around with that to kind of see what is the limiting factor for you and kind of best meet those needs as much as possible to optimize your PO intake.
But what happens if that person then can't eat and they have no tube? What is the options for them, do you think?
So in that case, if it really does come to a point of not eating at all, then you're going to have to discuss with the physician, what they like. So whether you really have a discussion about the level of care. So to see like what options they have, and have that discussion with the physician to see what their options are. Yeah,
that's a more challenging kind of question. And I think in the UK, the other option that we would consider is a nasogastric tube. And I don't know if you use those, which can be a very useful and safe way of getting food to the stomach. And yet it's something that's very hard to look after in the community, and carers can't look after it, and the nurses in the community refuse to look after it. So it really is 100% down to families, and that puts a lot of burden, I think, with the complexities of that. I don't know is that something you use?
We don't use it too often, just because the nasogastric option usually is like a short-term option. So so because of that, it's really down to like the level of care discussion to see if they want it for a short-term option, because really we don't usually send a patient home with it. It's really hard in the community to have that maintained. So because of that, it's less of an option that we use here.
Yeah, it's that's here too, I think. Thank you. Guðlaug. Julia Simon has a question for you about the thickening agent that's used in the food. Does it change the taste or have an impact on the person's health?
The thickening agents do not change the taste of the food, but of course there are a lot of thickenings that people can buy. Therefore, it is important to get the right thickening to use, and they are not affecting your health. They're just doing the texture right.
Yeah, thank you. There's an interesting question from Ducky from Vietnam, a really international audience here, and she's asked if there's an interesting case that you could share where somebody's had a feeding tube at a very early stage, and did they have MND or was it a different condition?
So I can start first. I actually had a patient that did have it. So they had bulbar onset ALS. So they did have a feeding tube inserted early on. Actually, they had it even before they started using it. So they had it done really early on because they already noticed that there's some change in their swallowing, and we had a discussion with them, and we told them that most likely their swallowing would be impaired to the point that it might be very difficult to eat enough. And because of that, he ended up getting a feeding tube early on. He was still eating his meals by mouth for a good, I would say, 2 months actually without needing the feeding tube. And when he first started using it, it was more for hydration purposes. So he just still was eating enough and, modifying the texture of his food and just getting hydration through the feeding tube. And then slowly, when he started to realize that swallowing became difficult, he started eating less, and really he was one of the people that I actually started, he still ate 3 times a day, just in smaller quantities. And then we just started supplementing with the feeding tube at the end of the day. And then gradually, as it progressed and he started eating less, then he just started eating, I think, 1 meal a day. He loves his breakfast. He wants to still continue eating that. And then he supplements with tube feeding at the end. So it did kind of progress, but the progression of the disease, I found, it's kind of slowed down because he was still able to maintain his weight. He was still having a lot of energy, finding pleasure with eating. So we try to maintain that as much as possible.
Yes, I think when I reflect back on some of our patients and, when we've done it at a good time, invariably is when we've been able to do it early, when they've been eating. And then there's that balance. They can supplement or not, or use it for water, or occasionally just medication. And then they might change gradually and in a kind of a controlled way to using it 100%. And I think that I kind of think cut out the crisis of needing to do something quickly or react, and people have time to get used to things. And I think when I do think back, that's the ideal time, isn't it, really, when things are done at kind of a bit, we are proactive in that respect. Thank you. Guðlaug, a question for you. Does all food for people living with ALS need to be blended or liquefied?
If people have dysphagia and swallowing problem, it is very important to have the food texturized. Of course, in the beginning, people start to eat soft diet, and then they do more pureed, and so it depends on the swallowing problem that people have. It's very important to eat, have the food in the right texture, just to be able to eat nicely.
Yeah, so it can vary, can't it, from person to person, I guess.
Yeah, because often I see that the people, they try not to, they don't want to eat the pure food because it just looks so bad. It destroys the appetite.
Yeah.
But so it's so important to teach people how to make a nice pureed food that is texturized and molded or shaped in the right way. It's so important.
Yeah, thank you. I wonder if either of you can answer this question, which is, what is the latest advice about vitamin supplementation?
What I found is the D vitamin is the D vitamin is very important, and it looks like that people with ALS is often low in D vitamin. Also B12 and these antioxidants vitamins are people often are very interested in those vitamins. But of course you can't get all those vitamins from food. So it is like the advice have to be personal for each individual, because depending how you eat, if you eat well and from all food groups, maybe you don't need to take vitamin except for D. You always have to take the D vitamin, because there are few food items that have D vitamin. But if people are not eating well, then we need to add often just like vitamins, so that you always have to see what people are doing.
Yeah, no, thank you. Madura, I have a question for you. And it said, how do you talk about the possibility? How do you introduce the concept of enteral feeding?
So really, the concept of enteral feeding, so that's something that I really personalize person to person. So especially if you do have the bulbar like weakness, so that weakness in your facial region and your jaws, then it is something that a feeding tube is something that you're most likely to need in the future. So we typically, for those patients particularly, we kind of like to have that talk about a feeding tube early on, but it really depends on each person. Some people at diagnosis, when they get their diagnosis, some people are kind of cope by trying to get as much information as possible to try to know how ALS looks like right now, and also at the end, in the very future when you do need a feeding tube, So some people like getting all that information. So for those patients, I give them all the information that they need. I answer their questions and give that to them. Some people, getting the diagnosis, as we can all imagine, can be very hard, it's overwhelming, they can't digest too much information. So for those people, you know, a diagnosis will probably not be the best time to address it. Instead, at their next visit, when we see them, which could be a month or 3 months later, and once they have time to digest the information, that's when we can slowly start to talk about, okay, this is how you're doing right now. This is the interventions that we need. However, in the future, if this gets worse, then a feeding tube can be an option. So just really, it's important to kind of introduce it slowly, to try to answer all their questions that they have and kind of go at their own pace. So some people, I kind of introduce it and they might not want to talk about it right away, but I give them a booklet with information, give them my contact card and say, when you're ready to talk about it, we can talk about it then. So it's really going at each person's pace.
Yeah, I think it is knowing the person as an individual, isn't it? And how they're dealing with the information and how they see. And, you know, food is so incredibly important, where the fact that things are changing has a big impact on their lives in many ways. But thank you for that. I think we've answered all the questions there. I think what I'd like to do is kind of just sum up slightly just the things that have my take-home messages, and it might vary for everybody, but my things are, you know, the importance of food. This is fundamental. I think we take it for granted so often as we eat, but every single occasion that we have with a family or friends involves food. And when that starts to change, that can be really difficult and it can isolate people. And I think Guðlaug talking about the importance of food looking good and being appealing and how to make that happen so people don't want to eat the equivalent. Often it's explained kind of contrasted into baby food. They don't want to do that. They want to eat food with everybody else in a social environment. And I think, Guðlaug, you've highlighted the importance of that incredibly well. And I think the jury, my take-home thoughts for you is about the timing, how incredibly important that is, and not leaving it too late, and kind of working with people, with individuals about their thoughts, about their misconceptions of a PEG, and working. And many people that I look after, they might say no to a PEG, but exploring reasons why they're saying no. And invariably, it's because they've misunderstood, or they didn't, you know, the concept of the PEG is very different, or they thought they couldn't eat and only use the PEG, or, you know, all of those things that you've discussed. And I think it's what you say, it's about kind of understanding people, working with them as individuals, and kind of taking their hand and walking through this journey of nutrition with them in a sympathetic way, and understanding that occasionally people don't want that. People do not want to have a tube. And I think sometimes it's because they tell me that they don't want to extend their lives. And I'm thinking, that's not something we could actually say that a PEG would extend life, because there's little evidence. But actually, so it's kind of just your skills that you share with the patients are so vitally important. But thank you for that. So any other comments from either of you that you'd like to mention?
No, I think you cover this very well.
You kind of summarize each of our parts very nicely, so thank you for that.
Okay, lovely. Well, thank you both very much for sharing your skills and your profound knowledge about food. I think I'm really grateful, and I hope people have found it very interesting. Sorry, we didn't have time for just one or two of the other questions that came in. But Jess, I wonder if I can hand back to you now.
Yes, you can. Thank you. On behalf of the Alliance, I want to say thank you to our panelists. Nutrition in ALS and MND is such an important topic, and your recommendations and information are of great value. In the short time we had during this webinar, you have covered so many considerations and clarifications. I want to thank you once again, our sponsor, Mitsubishi Tanabe Pharma, who makes this webinar series possible. And a big thank you to our audience for joining us today. And I wish you all a great morning, afternoon, or evening, depending on where you are in the world. Thank you.